to today's session of Changing the Way We Work, Community of Practice for Ontario Family Physicians. I'm Eleanor Colledge. I'm a family physician. I work in East Toronto, and I'm also the CPD Program Director for the Department of Family and Community Medicine. Really excited about today's session, and I'm going to turn things over now to our OCFP President, Dr. Jobin Varughese, to introduce things.
Thanks as always, Eleanor, and I want to thank everybody for coming today and welcome you to something that will feel a little deja vu because we have some amazing speakers for you that have been called back. I'm going to let Eleanor talk about that, but I'm going to just call everybody's attention to the fact that there's still a little bit of delay when it comes to the Cert Pro platform. This is a 1 credit per hour up to 32 credits. We will take care of that as you go to the next slide. We'll just show you that there is a way to also pay attention to the self-learning program. You can, if you've missed a session, you do want to earn credits. In some of the feedback, we've recognized that people don't necessarily know about this. It's a really quick 60-second survey that you can fill out to actually earn credits on sessions that you may watch afterwards, or if you're watching this one as a recording, you can earn credits from it. With that, I'd like to move to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects the Indigenous people have rich cultural and traditional practices that have been known to help improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And with that, I'll turn it back to Dr. Colledge.
Thanks, Jobin. And I'm calling in from Toronto, the lands traditionally used by the Wendat, the Anishinaabe, the Chippewas, the Haudenosaunees, and the Mississaugas of the Credit. And I wanted to reflect on today the fact that June is actually national, I'm sure many of you know this, National Indigenous History Month in Canada. It's our opportunity to recognize the rich history and heritage of the First Nations, Inuit, and Métis people. And this actually, you'll see this slide, there's a nice backdrop to it in the corner there. These visuals were put together to celebrate this month. So at the center of the visual, you'll see the sun. And that's at the center because it symbolizes the summer solstice, which is coming up on June 21st, and it's National Indigenous Peoples Day, and a very important day of celebration for many First Nations, Métis, and Inuit communities. And then there's also, you'll see a distinct symbol which represents each of the Indigenous groups. So there's the narwhal for the Inuit, the fiddle for the Métis, and the eagle for the First Nations. And the colors involved are to represent the 4 elements of nature, so the earth, wind, water, and fire. And then there's this colorful smoke that's rising through there, which is, again, to remind us of Indigenous spirituality and reflect the diversity of their communities. So I also was thinking about how to engage more actively in this month. I came across some great suggestions. So one is to hear the voices of our Indigenous people by, engaging with reading stories or listening to music. I'm currently reading From the Ashes by Jessie Thistle, which is a beautiful and challenging read. You can also explore the past and honor the truth, continue your educational journey. And I came across this really interesting app, actually. It's called Reconciliation, a Starting Point. You can download it to your phone and you can learn more history that way. And then also there's a really interesting GeoViewer map where you can check out about present day communities around where you live. So encourage everybody to think about what they can do this month. And with that, we'll go on to the next slide, please. So just a reminder that this is part of a series, and we have full, as a scientific planning committee, we work as a team to bring these sessions to you and to mitigate any potential bias. Next slide, please. And we've got 2 great panelists, both repeats today, so we're lovely to have them back, Dr. Dan Warshafsky and Dr. Rachita Gurtu. And next slide, please. So I'm just going to turn things over now to Dan to speak to his conflicts of interest.
Great. Thanks, everybody. Always happy to be here. Daniel Warshafsky, Associate Chief Medical Officer of Health. Nothing to declare. Thanks.
Thanks, Dan. And Rachita?
Hi everyone, thanks for inviting me. So I'm Rachita Gurtu. I'm a family physician working in Brampton, but I also work with the sexual health clinics with Peel Public Health. And just in terms of declarations, we received some honorarium for teaching family medicine residents through the U of T, and we'll be receiving honorarium for speaking here today.
Thanks, Rachita. Next, and Jobin.
Hi, everybody. Jobin Varughese. I'm president of the Ontario College of Family Physicians. I receive a stipend for that, as well as I have a role with Toronto Metropolitan University School of Medicine and William as interim assistant dean of primary care education, and William Ulster Health System as associate vice president of academics. Thanks.
Thanks, Jobin. And for myself, I get an honoraria from the OCFP. I also do some work for the Foundation for Medical Practice Education. And actually, I should include there that I also work within the DFCM. Nothing poses a conflict for today, though. Next slide, please. So just a reminder, if anybody happens to be new today, that if you have any questions to ask, please pop them in the Q&A. And if you see a question that you want answered, then upvote it, because I'll be prioritizing the ones that have the most upvotes to ask our panelists. And then just a reminder to use the chat box. This is the opportunity to network, to share resources, to provide comments. We really love how full of thoughts and comments it is as we go through the session. Next slide, please. All right, so at this point, I'm going to turn things over to Dan. Oh, actually, I'll maybe, sorry, just give you a breakdown on how we're going to run things. Probably pretty obvious, but we're going to start with Dan. He's going to do a public health update. We'll break for questions. Then we'll turn things over to Rachita for part 2 of STIs. And then we'll take questions. We'll make sure we finish all our main content by 9. And if we have to extend, we will. And now I'll turn things over to Dan.
Great, thanks, Eleanor. Rachita's is a public health update too. We're all together on this one today. But let's jump to the next slide. So first, just going to give an update on our measles outbreak. So as of PHO's data that we just posted yesterday, but it's as of June 3rd, we're over 2,000 cases now in Ontario across 19 public health units related to the specific outbreak. That's about 121 new cases reported since May 27th. I always caution that new cases doesn't necessarily mean cases in that week, because we obviously have delays in terms of when people are identified. But that is a bit of a downward trend since peak. We had at one point like almost 200 cases a week that are being reported. So based on that and based on some of the modeling PHO is doing, it looks like we might be in a bit of a downswing now in terms of new cases coming up. The numbers in terms of hospitalizations and ICU percentages are pretty stable at this point. We've had 140 individuals hospitalized, 9 ICU admissions. The median of those is relatively short stays. There's been a few people with much longer ones, but most of those stays are in the 2 to 4 day range in hospital, so not significantly ill, thankfully, for most of them. We've had 39 pregnant persons who have been diagnosed with measles and 6 cases of congenital measles. And as many of you probably heard yesterday, unfortunately, we had our first death related to this outbreak reported in an infant who had a case of congenital measles. They had significant underlying medical conditions as well. Measles wasn't the sole cause from what we understand, but it does really go to show the severity of what we're looking at. This is just like so tragic. These are preventable outcomes with immunization. We really hope that we can get people who are at risk immunized. And I have some more information on pregnant people coming up later in the slides, but this is what we've been doing our best to avoid. So this is really devastating to hear, unfortunately. Next slide, please. So this is that curve of cases. So as I said, so you'll see the gray boxes are several weeks at the end of this curve where we're still trying to get cases lumped in. So there may be cases added to any of those weeks as we go through. Obviously, some of those weeks go back into early May. So they're not, even though we might call new cases 150 next week, for example, many of those are actually older cases that are just being identified at this point in time and into the data that we get at PHO. If you look at the very bottom, you can see the trends for total new cases per week, and that's giving us a little bit of a better sense of how many new cases we're actually seeing. And again, it seems like we're probably on a bit of a downswing from the peak that we've seen. Next slide. This has also remained pretty stable at this point with the numbers. 94% of cases in the current outbreak are either unimmunized or had unknown immunization status. The main difference is that when you get over into the older adults, we see many more people with unknown status versus strictly just being unimmunized. But really the majority of cases have been unimmunized, particularly children and adolescents. Next slide, please. So this is the maps. Again, this is all from the PHO EPI report, showing on the left the cumulative cases, so total cases we've had in a particular area. The one on the right is giving a much better sense of what the current activity is for measles. So it's recent cases with rash within the last 21 days. 21 days being, of course, the longest that we'd see in terms of the incubation period for contracting measles from an exposure. So it gives a good sense of what parts of the province are still active with new measles cases. So you can see there's some areas that on the left map, had a fairly significant percentage of cases. These are all rates. Ones to call it are places like Southeast and Northeast Ontario. But if you go into the map on the right, those have really calmed down. So there's been good work done, put into place through local public health action and work of local healthcare providers to get immunization up and work with the affected communities, that we're not still seeing new cases arise in those parts of the province. So that's great. The most active area still remains kind of the core where things started in the heart of southwestern Ontario, with particularly those couple key health units, southwestern and Grand Erie Public Health being the core, but kind of those 4 surrounding health units you can see on the map where most of the cases are still being identified. Next slide, please. I have a whole bunch of reminders here. I'll go through very quickly on testing, everything you should be doing. Again, for testing, NP and/or throat swab and a urine for diagnosis. Serology is not required for diagnosis. It's really a helpful adjunct, particularly if you have someone who's immunized and you're trying to get a sense of an atypical presentation, whether or not be measles. Next slide, please. This is how you fill the requisition. We won't spend time on it. Next slide. And then reporting. So again, suspect cases, you don't have to wait for lab confirmation. Call public health right away. Report if you have a suspect case of measles, if they're unimmunized, if they've had a contact, if it's a very classic presentation. Just give public health a call so they can get started right away on post-exposure prophylaxis. Next slide. And again, so for IPAC consideration, so again, ideally within your clinic's offices, only people who are immunized should really be caring for patients who have measles. If someone comes in, provide them with a mask, get them into a room as quickly as possible, ideally seeing them to the end of the day if you can to avoid time with other patients. Try to get your staff's evidence of immunity on file. So this one is really important. We've had a couple episodes where there's been a case who's presented to a healthcare setting, and unfortunately staff didn't have their records available quickly enough, so the staff had to stay home for a few days from work until they could find their records of immunization. And then obviously that makes plays havoc in terms of clinic operations. So proactively just getting people in advance to dig up their yellow cards, get their immunity, call their public health, whatever it is, to make sure that you have just those records available so no one has to be excluded if there's a case. Next slide, please. So the outbreak strategy, so it's just a reminder of what we're doing. So in the affected areas, and these are in southwestern Ontario, there's a full list of public health units. Oh, I meant to put it at the bottom. I didn't get the whole thing in. It's at now roughly 10 health units, I think, that in southwestern Ontario where we're using this strategy. Basically, it's that early dose for infants under the age of 1, and then moving up the second dose for infants not until 4 to 6. But to having it as early as possible after the first dose. Again, this is for the areas of the province where we are seeing that significant spread, particularly in southwestern Ontario. And there's a full list, and there's a PHO website that lists them all, the regions. There's materials coming out from the ministry as well, and so there's lots of places to find that. If you're in one of those regions or you have questions, you can always just ask your local public health unit if it applies to you and your patients. Next slide, please. And again, you don't have to do serology on everybody. It's not recommended after giving a vaccine. It's not 100% reliable. The best is that if someone's received 2 doses of a measles-containing vaccine, we're considering them immune. You don't have to check serology on those people afterwards. If someone doesn't know the records, they have no way of obtaining them, you should just give them another dose. Next slide, please. Okay, so for measles in pregnancy, so again, there's a couple particular concerns we have. Individuals who are pregnant and get measles while they're pregnant, there's a risk of maternal complications, particularly things like preterm labor or pregnancy loss, low birth weight, and then congenital measles infection to the infant. Measles doesn't have teratogenic effects. It's not like rubella that we're concerned that will be congenital anomalies due to measles. But congenital measles is something that can happen, and has happened 6 times so far in Ontario, where the infant is born. Often they get a rash like in their first day of life, and then part of the care is struggling to make sure that they make it through their initial measles infection at such a young age. So if you have pregnant patients, again, just check their measles status prior to pregnancy. Ideally, if people are thinking of getting pregnant or anybody of childbearing age, just make sure that they're up to date with their immunizations. If they're already pregnant, at least get their records and confirm. If they're not immune before pregnancy, you should try to give it at least 4 weeks before they become pregnant. You give it as soon as possible after someone's become pregnant. And then if they are pregnant and know not to be immune, counseling them on just how to avoid that, to reduce their risk in terms of actually contracting measles. Next slide, please. Okay, that was the quick measles update. I'm going to talk about Lyme disease just because we're in the season now. And it continues to increase every single year. So last year we had over 2,000 cases of Lyme disease reported across Ontario. It's been going up fairly steadily, primarily due to climate change, and we're seeing an expansion of the territory of the ticks that cause it. It's also getting to be a much longer season now, from spring, summer into the fall, as we again see those effects of climate change. Once we've already had 85 cases to date as of this year, and it's pretty early in the season still. So next slide. This is just a quick map of which are the hotspot regions in the province. You can see again, it's been spreading pretty steadily northwards for a number of years now. So most parts of Ontario at this point are at risk for Lyme, particularly in southern Ontario. So it's especially any wooded areas, brushy areas, that's where we see these ticks, and there's a significant risk. Next slide, please. So tick submission is not required for surveillance in most parts of Ontario, again, because we just see Lyme in so many of these areas. If you do get ticks and you have concern, you can still submit them for identification, but you don't have to do it for surveillance purposes anymore. And again, we have a really good sense of what the areas are in the province. Next slide. So prevention, again, going into what areas, want to cover yourself up, closed shoes, tuck-in shirt, long sleeves, long pants, insect repellent, all of those pieces. Anywhere you're outdoors, again, to just avoid heavily wooded areas. If you can walk on paths and trails, it's much easier to avoid the ticks in that case. And when you're coming indoors, do a full body check if you've been in any of these woody areas. People often don't feel if they've got a tick on them, so particularly for children, pets, you want to take a look and just see, are there any ticks attached? As soon as possible, try to wash off those unattached ticks, and if you find it, remove it by the head. Next slide, please. And so this is just a snapshot of the new, from Public Health Ontario, their vector-borne disease tool. So Lyme disease is one of them, but it covers all the vector-borne diseases that we commonly see in Ontario. So these being the major ones, you can see Lyme disease is obviously the highest that we see. We'll get significant numbers of West Nile at some point. The other tick-borne ones we see at lower rates than Lyme disease, but again, certainly issues. At the bottom, and sorry, it's very small, there's little tabs, and you can go to each specific one, and it'll pop up maps like you see on the next slide here. This is another line map that I showed for the slide, but you'll get a map like this for all regions, for whichever disease you pick, and it shows again really where the hotspots in the province are for any particular one of those vector-borne diseases. So it's a great tool. Links are on the thing and links are in the chat, but it's just been put up by PHO, and again, really good way to get a sense of what might be circulating in the regions you're practicing. I think that's it.
Great. Thanks so much, Dan, for bringing us up to speed and also getting us up to speed again on Lyme disease. So a couple questions for you. I'm going to start with the ones that are not measles or Lyme related. So the first one was just around COVID. What metrics are now good to follow to track COVID activity locally, hospitalizations, wastewater? Interested in your thoughts there.
Yeah, I refer people to PHO. PHO has so many tools now, like it's getting really, really good. But the respiratory virus tool that they have is still the best way to get a sense for COVID, flu, RSV, and the other less common ones. They do have maps by public health unit in terms of the rates that we're seeing in each region. And it follows a variety of trends. So it looks at cases, it looks at percent positivity of tests in the region, looks at hospitalizations, looks at ICU admissions. And probably, and outbreaks as well that we're seeing in places like long-term care, other congregate settings. So that gives us a really good sense of what we're seeing for any of those respiratory disease trends, to get a bit good understanding. And again, it's by region. Probably things like percent positivity is one of the earliest indicators of getting the testing that we're seeing increases. Things like hospitalization and ICU admission, of course, lag by a few weeks from cases and percent positivity. But again, together, it's like a pretty full scope trend to get a good understanding of what any of those respiratory illnesses are looking like across the province.
Great. Yeah, it's good to know that those tools are online and nice to see more and more availability in terms of what we can just check for ourselves. Another question around COVID and the flu. If someone didn't get the flu or COVID vaccine this winter, should they get it now or should they wait until the fall?
Yeah, so our high risk program is on right now. So anyone who's in the highest risk categories, so it's older adults, people with significant medical comorbidities or immunocompromise. Again, sorry, I'm sure we'll put the link in the chat after as I'm talking of who's eligible. But that's on right now, and any of those individuals, I absolutely would strongly recommend that they get the vaccine now. I think at the last talk, Allison I think mentioned the new strain, the NB, that we're seeing starting to increase. That has entered into Ontario and Canada. We're seeing in the Public Health Ontario lab report on COVID, which I think was just posted yesterday as well. It is an ever increasing proportion of cases, and it's really probably going to drive our next wave in terms of COVID, which is likely to be probably in the next month or so, like another summer start to COVID wave. So certainly if someone's high risk, I would strongly encourage that they're getting it right now. For those who don't meet the eligibility criteria now, they'll of course be waiting until the fall, but we'll be having an updated product in the fall that hopefully is a better match to the current strain.
Great, thanks for clarifying that. Another question just in terms of circulating viruses, is the influenza A and RSV season over?
Yes, and so again, that's also in the PHO tool. The RSV season ended probably in late February, early March, just depending where you were in the province. So that's officially done. And flu a little bit later, but roughly in the same time of the year, kind of the late winter, early spring. So flu and RSV are at extremely low rates right now. Again, COVID is also quite low right now, but we're just starting to see that increase based on that new strain that's arrived.
Great, thanks. It's nice to know some things are going down in terms of infectious diseases, at least periodic, at least for now. I'm going to turn things over to measles. So a couple of questions around just in terms of vaccination. So if somebody doesn't know whether they've had an MMR and you don't have any records, would you do 1 or 2 doses for those people?
Yeah, so again, if they're born after 1970 in Canada and they have no records at all, the best is to just give them a 2-dose series. Again, like serology is not as reliable as we'd like it to be. If they are adamantly refusing to receive doses and insist on serology, I mean, you can do that, but they may come up negative even if they have received doses. So the preference is just to immunize right away for those individuals. And that way they will have that record for anything going forward that we know they're protected.
Okay, so if they're not sure and they're born after 1970, best just to give them 2 doses if they really don't know.
Yeah, absolutely.
And what about if they weren't born in Canada? There was a question around that. If they were born after 1970 but not in Canada, would that be the same guidance for those folks?
It's a great question, and often we see, particularly people who have immigrated recently are less likely to have their records available. So it does depend on the location. So some countries had low rates of measles earlier than Canada. The big ones that we see a lot of people coming to Canada from are the US or the UK. US is actually 1957, so quite a bit earlier. UK was, I want to say, 65. So it is a little bit different depending on the country. For most other parts of the world, particularly outside of Europe and the United States, it's a much later year where they would have received those vaccines and things were circulating for longer. Again, if they don't have records and you just really don't know, the best advice is to just give them 2 doses and get them up to date. Otherwise, you can always check by particular country what that age range is going to be. WHO often has a good link of all countries, what their schedule is like and when their kind of elimination status, if they achieved it, was. There are certainly countries still right now that have never achieved the low levels we've had now. And if you're coming from that country, they likely were exposed to measles. But again, if they don't remember that they've been exposed particularly and they don't have records, best is to just immunize them.
Great, thanks, Dan. Another question just around if you are in a situation where you've had to test somebody for immunity, for example, for school or work, and they're non-immune after having had their primary series, would you then still recommend 1 or 2 boosters?
No, it's a really good question. So this is why we strongly do not recommend serology after someone has received their doses. Again, so the serology is only one part of your immunity, right? Like we have our humoral immunity antibodies. We have separate cell-mediated immunity that we just can't measure on serology. Both of those are involved in your protection against measles. Even if someone isn't showing up positive on serology, if they've had 2 doses, they probably still have really good protection against measles based on their cell-mediated immunity and then the memory response that they'll have. So, if you have confirmation of 2 doses, definitely please do not do serology on somebody. That's considered immunity.
Okay, great. Yeah, and I think many of the forms it says if you've had 2 doses, you don't have to do immunity. So that's good. This is more of a question just around whether there's any evidence that the measles outbreak is causing any shift in attitude towards vaccination, especially among those who've been infected. Comment from Peter that it would be good to get feedback from people who might have changed their minds. Wondering if anything, if there's anybody looking into that or studying that at all.
That's a great question. So we can say at the local level, obviously our public health units are working very closely within these affected communities. And certainly there's been an increase in immunization, and we can see that very clearly in southwestern Ontario, even among populations that historically have been more reticent to receive immunization. There's been big uptakes. Case in point is what happened in Southeast public health on the map that there's now white when it was bright red. They had excellent response from that community in terms of immunization. We're able to get things under control. So it absolutely has been shifting attitudes, at least in those areas. I think in terms of are there broader trends that we're seeing in Ontario or Canada as a result of this? I think it's a little bit early to say. There are some groups that are doing those surveys fairly regularly, and hopefully we'll see those results soon. Likely we'll see a small increase in overall acceptance. I don't think this is going to shift us 10% in terms of people who are anti-vax, but it's certainly for those on the fencers, just seeing the risk and making more clear is something that we have seen is increasing the agreeableness to immunization.
Great. I mean, that's good to hear. So going to just change tracks a little bit because we have a question here about Gardasil.
Sure.
So is Gardasil 9 2 shots equivalent to 3 shots, or is it potentially a cost-saving measure?
Good question. And so the most recent NACI statement has a lot of detail on this. So I'll give a very high level, but encourage people to take a look if they have questions. We have excellent evidence that the 2-dose series and the 3-dose series are equivalent. There's non-inferiority in the 2-dose series compared to 3-dose series. We feel very, very strongly that those are equivalent. It's not a cost-saving measure. That's what we're seeing in the evidence. The newest NACI statement, of course, said that you can go down to 1 dose for a particular age range. So not for everybody, but for essentially the adolescents most common program. NACI is recommending the evidence we have at this time, such that even 1 dose gives you equivalent protection. The studies we have on that go out to about 11 years in terms of following efficacy and effectiveness in the real world as well. And what we see is that at least at that 11-year mark, we don't see significant decreases in effectiveness. Is it possible that after 11 years it decreases? Of course it is, but it's not like we're going to hit 11 years and then boom, it's going to go straight down in terms of the effectiveness. Like it's not going to suddenly drop off a cliff. That's just not how your immune system responds. So there are more studies. There's actually a couple of big ones that should be coming out in the next month or so with some larger RCTs, in the tens of thousands of people that are looking at that 1 dose and 2 dose as well. So a little bit more to come probably by like July, we'll have those. But again, the evidence we have to date shows non-inferiority, certainly from the 2 to 3 doses. And again, for that particular age range, we see for the 1 dose looking like it's just as good as well. And I say that age range because obviously your immune response changes over age. And so we really want to stick to the evidence on which ages we have good evidence to suggest the non-inferiority of those schedules.
Great. I mean, it sounds very reassuring in terms of the 2 doses for sure, and perhaps some changes coming in the future. I'm going to give 2 last questions before I turn things over to Rachita. I think those of us in Toronto might have seen that it was very smoky in the air yesterday. And just a question here, Dan, can you talk a little bit about wildfire smoke risks and what we should tell our patients, noting that today's in Toronto, the air health quality index is 7.
Yeah, and so on the HQI also gives recommendations kind of like by risks and comorbidity for individuals. So what we see from, wildfire smokes tends to be a lot of particulate matter that's put into the air. That's probably one of the things that causes most symptoms in individuals. So particularly anybody who has underlying respiratory conditions like asthma, COPD, anything like that, these are the days to stay inside as much as possible. It absolutely will aggravate underlying symptoms significantly, and potentially leading to, exacerbations of asthma, having to go to hospital, that sort of stuff. So if someone does have the underlying conditions, they should be watching that pretty closely, and that's how I would counsel patients on. If you're above this level, then you should really be staying indoors as much as possible on those days. Even for someone who doesn't have underlying respiratory conditions, when we get to those higher levels in the AHQI, we see just irritation and effects. So people who are just outdoors in smoky times, I think I remember it was last year, 2 years ago now, where like all of Toronto was under a fog when we had the significant wildfires. Like anybody going outside was going to have respiratory issues just because of how significantly poor the air quality was. Again, within those indices, it does give a sense of, this is okay for everybody. This is okay for people who don't have conditions. This is everybody should stay inside as much as possible. So I would just encourage you to follow the directions basically on the indices in terms of counseling patients. I can't remember which numbers offhand are where the breakpoints are. I want to say 1 to 3 is okay for everybody, and then kind of over 4 or 5 if you have conditions you want to stay inside, but don't quote me on the numbers right now.
All right, we won't quote you on the numbers.
Thank you.
But appreciate your answer to the question. And just the last question before we turn things over to Rachita, and then if we need to, we'll come back to you. There's a few remaining questions in the chat, but just in terms of ticks, do you see them in the grassy areas of Toronto? There was a question about that.
We in the grassy areas of Toronto, we still can't. So absolutely, we do see these ticks in Toronto. Toronto obviously has a lot of ravines and wooded areas as well. That's mostly where you see them. I don't totally know what people mean by grassy areas. Like we won't see them on like a football field or a baseball diamond. Like that's not it. It has to be something with a little bit of tree cover or brush. But in areas that are like significantly bushy or brushy, and particularly any of those like wooded parks in the city, absolutely we do see these ticks, and that is a risk.
Okay, great. Thanks very much, Dan. We're going to turn things over now to Rachita.
Hi, everybody. Thanks for having me back. So I'm going to be doing, I guess, a part 2 on testing for STIs in primary care. Next slide. So our focus today is really going to be on genital herpes and trich. So we'll be talking about the testing indications for genital herpes and trich, the available tests that we have here in Ontario, and treatment recommendations for both of them as well. Next slide. So we'll start with genital herpes. Next slide. So as you know, this can be a really stressful diagnosis for a lot of people, as there is a lot of social stigma attached to this. I find this can be one of some of the appointments that take actually a longer time in terms of the counseling when I see patients who have been diagnosed with herpes. So I just thought I'd sort of summarize some like key points that we'll often talk about with patients. So this, I think, sometimes is helpful to reassure them that this is a common condition. So there's some estimates that approximately 14% of individuals aged 14 to 59 years old in Canada do have HSV2. It's important to let people know that even though this is a chronic infection and they are going to have reoccurrences going forward, it is a manageable condition. So we are really fortunate that we do have medications that can sort of manage their symptoms and also like reduce the possibility of transmitting it to their partners. Often people can have this infection for some time in their body and it can go undetected or unrecognized. And sometimes people will ask you, like, what does this mean? Does this mean like my partner was cheating on me? Does this mean like, when did I get this? How did I get this? So it's often helpful for people to know that, no, it doesn't necessarily mean that your partner has had another partner that you don't know about. So maybe your partner has symptoms, or maybe even you've had symptoms and didn't realize you had it. Because sometimes people can have symptoms and they can be very mild, short-lived. They really don't have obvious symptoms, or often I find they might have had symptoms and they chalked it up to being something else. For example, sometimes I've seen people like it's such a small lesion that they'll be getting and they chalk it up to, oh, well, I had gone for waxing, or it's because I shaved, or they were at the gym and they thought, their clothes were chafing against the skin. And so they have another explanation and never really seek treatment or see anyone for it at the time. And often people ask about, condoms, are they going to help? So yes, it will reduce to a certain degree. However, it doesn't eliminate the risk of transmission or acquisition. You can think about it, really depends like where they have lesions, and it's through skin to skin, and condoms only cover so much. And then just put a link at the bottom there in terms of resources. There's some really helpful counseling tools there on the STI guidelines website. Next slide. So I think the big question that everyone always asks about is like, what do I do in terms of testing? So really, the best way to test and like to diagnose for HSV is to do a sample from the lesion itself. So now we have NATs that are available, and the sensitivity and specificity is like, if you're getting a good sample, closest to like 100%. And as many of you know, and I think, a question that always comes up is like, when do we do blood work? So we do have blood work that's available, so the type specific serology. However, this really is not recommended as a screening tool. So if someone's never had symptoms before, it's not indicated to do as a screening tool. So often you'll have patients who come in, they like want to get, I just want to check out, quote unquote, that I'm clear from any STIs. And often, people will get this testing done, but it's not recommended really to use this as a screening tool, as sometimes like the answers are honestly not very helpful if someone's never had symptoms. However, there are some specific times where you may want to consider doing the blood work. So for example, if someone's had symptoms or signs or symptoms of herpes, however, like maybe the spots have dried up, and really getting a sample is not feasible at that time, maybe you might want to do blood work at that time. But however, waiting until like if they have another outbreak and doing a sample from the lesion would be preferred over doing the blood work. And often I'll tell patients that as well. And the only other time that you might want to consider doing it is someone and their partner both know that they have genital herpes, so they've had outbreaks before. However, they don't know what type they have, so HSV1 versus HSV2. So it may be helpful to do blood work on those people, because if they have serodiscordant type, so one has HSV1 and one has HSV2, theoretically they can, pass that infection on to their partner. So that might be something that's helpful for them to know. Next slide. So in terms of the testing, this is the swab that you use. So I think most of us have us in our office. So if you have a lesion, you're just kind of scrape this, or, like rub this around there. Sometimes I'll like de-roof one of them just to get the liquid, and then you send it to the Public Health Ontario laboratories, and I've just put a sample of like what the requisition looks like. So really important just to sort of specify like where you got the like the location of the where the swab was taken, and then just writing HSV NAT and then sending that in through your lab. Next slide. So in terms of treatment, so this is for non-pregnant individuals. So sorry, this is a little bit of a busy slide, but as you know, we do have different treatment regimens that are available. And I think most of us kind of have our favorites that we go with. So as you can see, they're all pretty similar in terms of like they have A1 indications. So for primary episodes, we have the different regimens over there. And really what we're trying to do is help with their symptoms. It is recommended anyone who's kind of experiencing their primary episode that we do offer them treatment, unless they've absolutely like had all the lesions dry up and they're completely healed. So then there's really no point. So you can see the different regimens there. Again, everyone's kind of got their favorites. I personally tend to lean towards valacyclovir just more because of the ease of dosing. It's a BID dosing, but again, all of you, pick whichever one kind of works for you. You will see that there is a little bit a preference in terms of how many days like after symptom onset. So some of them give you like a better margin. So acyclovir, you can ideally use within 7 days. So it kind of gives you a little bit more flexibility, but it is a bit cumbersome to take, 5 times a day. Episodic treatment, again, we have different regimens available, and the key thing to remember is that really we're trying to start the medication as soon as they're feeling any of the prodromal symptoms, and our goal is we're trying to shorten how long they're going to be getting their symptoms for, and how severe the symptoms are going to be, and hopefully like decreasing the likelihood of spreading to others as well. So again, there's different regimens there available. Valacyclovir and Famvir may be having a little bit better efficacy. And so again, picking whichever one sort of works better for you. I'm not sure off the top of my head if there's a huge difference in terms of cost, to be honest, but that might be something that also kind of plays into your decision. And then for some people, suppressive treatment might be something that, is important for them as well. So really the goal of that is to reduce how often they're getting their outbreaks and how long they're lasting for. But often the reason why a lot of people want to take this as well is because they want to make sure that they're not spreading this to their partner. So again, different regimens that you can use. So we have valacyclovir, and it comes with like 2 different dosing depending how often people are getting outbreaks. And then again, acyclovir and famciclovir as well. So again, picking one that works for you. Again, I tend to prefer something that's easier to take for people. So like a once a day dosing, but again, working with what works for you. If a patient's finding, they're taking one regimen and they're still getting lots of outbreaks, it would be reasonable to try a different medication. Maybe that one's a better one for them. Next slide. So in pregnancy, now it's been a disclaimer, I haven't done, pregnancy, well, 3rd trimester or like deliveries in quite some time. So there may be some on this call that are probably a bit more experienced in dealing with genital herpes at the time of delivery. But just in terms of, as we know, genital herpes, what we're trying to do is make sure that it does not go to baby, because there is a risk of vertical transmission like during delivery. So if someone's experiencing their first episode ever during pregnancy, where acyclovir is the medication that you want to use, sometimes there's going to be that indication for C-section, just because we're trying to prevent it going for baby. And particularly if someone is getting their first episode ever in the 3rd trimester, that would be an indication for C-section. If someone has a history of genital herpes, then we do want to put them on suppressive treatment, particularly after 36 weeks, and continuing it on until the end, like by the time that they're ready for delivery. And so particularly for those who have a history of HSV2 specifically, or they, that they've had like recurrent episodes in the previous year. And again, if they do have like lesions or any symptoms at the, as when they're getting closer to time of labor, like in labor, then that would be an indication for C-section, because we really do not want this to go to baby. And again, like acyclovir would probably be preferred, but valacyclovir, there's some dosing there as well for suppressive treatment. Next slide. So we'll just kind of move over to trichomonas. Next slide. So I will preface this can be really difficult and sort of confusing infection sometimes to like test and treat for. So just some like information just to kind of reiterate stuff that you might already know. So it is a protozoan infection. This is not a reportable infection in Ontario. So it's not something that goes to public health. However, it is a sexually transmitted cause of vaginitis. So you will see it through, it can be transmitted through penis and vagina sex, vagina to vagina, for like the fluid exchange, or vagina, or any toys and fomites. Often it can be asymptomatic, and I've seen sort of varying sort of percentages in terms of how many people, like how like the incidence for that. But particularly in males or trans females, they're not really going to have any symptoms. However, for those who do get symptoms, as you know, vaginal discharge is a common thing that people will complain about. It can be like a yellow greenish color, thin, kind of large amount. Sometimes it's described as being frothy. They can have erythema in the vulva or the cervix. So the classic is that strawberry cervix. But sometimes people have vague, itching, dysuria, burning type symptoms as well. So it can be sometimes hard to know whether the symptoms are due to trigger or something else. Next slide. So in terms of testing, so obviously if someone has symptoms, we're going to think about testing, and we'll talk about the swabs in a moment. But I know the question often comes up like, well, what about people who don't have symptoms? Because you just said, people often don't have symptoms and they have it. So really, who should we be screening? Unfortunately, there's really no clear recommendations for asymptomatic screening that I've been able to see through Public Health Agency of Canada or even the CDC. And I think largely it's because there's really data lacking in terms like whether, like if we actually screening and treating people, whether that's actually reducing any adverse health outcomes or community spread. However, that being said, there are some populations maybe you might want to consider screening. So for example, in pregnant individuals, maybe that might be a group that you might want to consider screening, particularly if they have other risk factors for STIs. And the reason being because the trichomonas infection during pregnancy may be associated with premature rupture of membranes, preterm birth, and low birth weight. However, again, that being said, it's not really known whether if you treat them, that's really going to change their pregnancy outcomes. So a lot of times it's going to be for symptomatic management, but may or may not have some change in whether the outcomes of the pregnancy are any different through treatment. Other populations that you may want to consider screening, those who have other risk factors for other STIs. So like we talked about last talk, people who maybe have multiple sexual partners, those that may be incarcerated, people with a history of like drug use. So, and again, the rationale for that being having trichomonas infection is also associated with an increased risk of HIV acquisition or transmission. So if people are at risk of like having other STIs and they have like trick, we're maybe more concerned for those individuals and may want to consider screening those. And then for females or trans male patients that are living with HIV, so trichomonas infection has been associated with an increased risk of PID in this population. So another population that you may want to consider screening periodically as well. Next slide. So in terms of testing, what tests do we have available? So we do have NAT testing, and it is much more sensitive and specific compared to the cultures that we have available, and we can do it through vaginal, endocervical, and urine sites. The endocervical and the vaginal tests are preferred for our female or trans male patients, and urine's really more for our male or trans female patients, so more like the partners. And if you are doing urine tests, it's the first catch, so similar to what we do for chlamydia and gonorrhea, not the midstream urine. And just as an aside, you can use the same swabs or the urine sample to also check for chlamydia and gonorrhea while you're at it. And then I think the vaginal cultures most of us are familiar with. So often when people are presenting with symptoms, we're also testing for other things like for BV, plus or minus yeast. So that same swab can also be used to check for trichomonas. Next slide. So which swabs, what do they look like? So I think most of us would be familiar with this one. So this is the endocervical swab that you can use. And again, you can use the same swab for chlamydia and gonorrhea. So especially if someone's symptomatic, you're in there doing a swab anyway, you're going to send the swab off and mark chlamydia, gonorrhea, if that's what you also want to test, and trichomonas, all on the same requisition, all from the same swab. Next slide. Dynacarine life labs again. So this is another test as well that you can do. This is the multi-test swab. This one you can use as a vaginal sample. And you can see here we're doing the chlamydia and gonorrhea testing as well. And we're doing it all on the same requisition. Just an aside, as a reminder for those of you who listened to the last talk or maybe missed it, this often people ask about which swab to use for throat and rectal swabs when we're checking for chlamydia and gonorrhea. This is going to be the preferred swab to do that as well if you're using Dynacarine life labs. So we can do this. Obviously, you're not going to be checking for trichomonas in their throat and rectal areas. But if you needed to do those other sites as well, this would be the swab that you'd be using, but a different swab, of course. Okay, next slide. And for urine sample, so again, like I mentioned, this is the first catch urine. Ideally, you just want a small sample, concentrated sample of the initial urine stream. And again, you can use this for chlamydia and gonorrhea testing as well. And like I mentioned, this is really more for male or trans female patients that we're going to be doing urine samples, as the vaginal or the cervical samples are preferred for anyone with a vagina. Next slide. And the CNS vaginal swabs, again, you're all sort of familiar with them. They kind of look different depending on which lab you use. Sometimes it's a red top, sometimes it's a blue top. But this is the swab that you can use. You can also use a charcoal swab. And as a reminder, the charcoal swab can be used for gonorrhea culture as well, in case that's something you're wanting to test for. But vaginal CNS, any of these swabs are okay. And again, the requisition, just try check the vaginal sample there on the side. Next slide. So in terms of treatment, metronidazole really is a medication that's preferred for treatment. So for non-pregnant individuals, you can sort of do either the single dose or there is the BID dosing as well for 7 days that you can use. Both would be fine. Key to note, though, that the intravaginal metronidazole gel is not effective for trichomonas. So I know sometimes we will use that for BV treatment. But if you're thinking about trichomonas, then it would be preferable to go with the oral treatment and not do the vaginal gel. In pregnancy, again, same dosing. So you can use the 2-gram dosing in a single dose. You can use the BID dosing as well as an alternate treatment. However, like we talked about earlier, really not known if it's going to change pregnancy outcomes in terms of the risks that we talked about. It's really more for symptom management. And again, really important to make sure that we're treating any current partners that they have with the same treatment regimen. Next slide. So in terms of repeat testing, what should we be doing in terms of follow-up? So if symptoms persist, absolutely, we want to do some testing again. However, there's no recommendations really in Canada in terms of doing a test of cure after someone's been treated for trichomonas. However, CDC does suggest retesting all women or trans men 3 months after treatment, and due to the high rates of reinfection, but they don't really suggest that we retest any men or trans females because really we don't have sufficient data. So again, as you can see, not a lot of clear guidelines. So you may just need to sort of think about, the client in front of you and some of the other risk factors that may be present and whether it might be something that we need to do. Next slide. So key takeaways, I think, for today. So in terms of herpes, I think main thing to take away is really the counseling part is really key because it can be a very devastating diagnosis for many people. For testing, swabs are the preferred method, and the serology is not recommended in terms of a screening test. Only some key scenarios where you may want to consider it. For trichomonas, as we said, it's an STI-associated cause of vaginitis. We're testing those with symptoms using that preferably, or you can use the CNS sample as well. Treatment's really for symptom relief, and we really don't know if there's data that treating it's going to change their health outcomes or community spread, and really no clear guidelines for asymptomatic screening for trichomonas, unfortunately. However, like I said, there may be some populations where you may want to consider it depending on the population that you're seeing. Next slide. And I've just linked some links. There's some links there in terms of resources that you may want to turn to. Yeah, that's everything from my end. Thanks so much.
Great. Thanks so much, Rachita, for taking us through those two topics and giving us some guidance in terms of how to manage things. A couple of questions for you just around herpes. First question is, can herpes be transmitted when there's no symptoms?
Yes. So unfortunately, that is the part that really messes with people and causes a lot of angst because yes, you can have some asymptomatic viral shedding. So they're going to be most likely to spread it when they have symptoms or right before in the prodromal phase. But yes, it is theoretically possible to still spread it when they don't have symptoms. And that part is the part that's really stressful for people and where that counseling piece comes in.
Absolutely. I guess along the same lines, you had commented because it can be asymptomatic. How long after sexual contact can somebody be relatively confident that they haven't contracted HSV? Is there a way? No.
No, in my experience, if someone's going to get symptoms, they're usually getting it within a month or so. But again, it's so hard to know. And so I find that's where these appointments take a long time because a lot of the answers are, I'm not sure. And I don't know because it can be so variable person to person.
Yeah, that's helpful. In terms of those that have, there was a question actually about the type-specific testing, because you'd mentioned not to use it except in certain circumstances, but somebody was wondering, could you use it if somebody had been exposed and was wondering whether they were going to get it? Like, would you ever use it in that type of circumstance?
I don't personally, just because again, for all these variables, so there's a couple pieces to this. So it can take some time for the immunity to build up enough to actually show up on the test. So it also depends on timing of after exposure when you've done it. So have you done it too early and you just didn't capture it? And sometimes people will get these tests done and they'll come to see us because, they've had testing done in the community, and then they'll come to our clinics and they're, say, HSV, like 1 or 2 positive for antibodies. So, and then they're wondering, what does this mean? And honestly, I never really have a good answer for people because honestly don't know. Do they just have antibodies because they've been exposed? Does this mean they're going to have an outbreak? And again, I don't know. And then the question comes up, well, what does this mean? Am I going to potentially spread something? And again, like, I honestly don't have good answers for people. So my kind of rule is, I don't do testing if I don't know what I'm going to do with the answer. It's not going to change management for me. So that's also part of why I don't like to do the serology, because often if they haven't had symptoms, it's not really helpful for me and actually causes more angst for the patient than actually helps answer, like, management wise, what to do. So sorry, it's a very vague answer, but because, like, honestly, I really don't know what the right answer is, and I don't know if others have experience, please drop it in the chat. But yeah, I find it not very helpful to do the test and really stresses everybody out.
Yeah, no, I think you're just speaking to the reality that we're all facing. So yeah, we hear you. Actually, there's a question that I just happened to notice in the chat. So if a patient has known HSV and their partner does not, or hasn't had symptoms, would you be recommending, I presume, that the patient go on daily prophylaxis to
So if the
prevent?
patient's the one with HSV and their partner does not have a history, then yeah, often we'll have that conversation. I honestly encourage people to have a conversation with their partner and, like, transparency. And I kind of always think about, like, if my partner had it, would I want to know? So it's easier for those who are in a, like, longer term committed relationship to have these type of conversations. And I've had some patients that, they talk to their partner about it. Um, and the partners understands the risk, and they decide or not decide whether, the person who has HSV wants to go on suppressive treatment or not, or they manage it by minimizing contact when they're having an outbreak. People who have more casual partners or not in a committed relationship, often I find, are opting to go on suppressive treatment because they don't want to be in that scenario where they've potentially transmitted it to a partner unknowingly. So it's about kind of reducing possibility as much as possible. Unfortunately, nothing's 0 or 100% in medicine, but sometimes they're wanting to go on the suppressive treatment for those reasons, because they don't want to pass it on.
Right. Great, that's helpful. Just in terms of suppressive treatment, a couple of questions about that. So for patients that are on suppressive treatment, are there any guidelines on when to consider stopping therapy? The understanding being that over time outbreaks may become less frequent in some patients.
No, I mean, I think it just really depends on the person and sort of their scenario that they're in terms of, again, their acceptance of risk, and, whether they're concerned about passing it on to a partner or partners. So really kind of stay using it as long as they need to.
And in terms of just treatment generally, have you heard of any people, or can it be possible for people to develop resistance to some of the treatments, for example, Valtrex?
Not that I'm aware of. I mean, definitely I've seen people, like, I had one patient, for example, they were immunocompromised and they needed higher doses when they had outbreaks. But I have not heard of anybody. I guess if something stops working for them, there's also the possibility of maybe switching over to one of the other medications would be a possibility. But offhand, no, I haven't heard about, like, resistance.
Great. And in terms of treatment, if you have HSV1 in the genital area, do you treat it the same as you would HSV2?
Yes.
Yeah.
And just as an aside, I think people, like, I've really started telling people that you can get herpes through, like, oral sex. I think people just think about oral sex as if nothing can happen from an STI perspective. So it is on the list of things that you can get through oral sex transmission. So we are seeing a lot of, like, HSV1 down in the genital area now.
Great. And if you don't mind, I'm going to switch a little bit actually just to ureaplasma, because we had a couple of questions on that. Oh dear. Just in terms of, first of all, like, and I think you did touch on this actually in our last session, that, like, how and when you might test for ureaplasma.
Yeah, so there is a swab that you can do. So it's actually the same swab that we use for herpes, that red top one, that you can send to Public Health Ontario. From what I've read, and it's coming up a lot more. I don't know if it's on TikTok or on social media or something, but, like, people are coming in a lot to ask about ureaplasma. So from my understanding, not an expert on ureaplasma, but It can be something that can normally colonize, particularly in the vagina, and so it may not be your culprit. So we don't recommend like using it as for screening. I will do it on people who are symptomatic. We've ruled out like our usual offenders like chlamydia, gonorrhea, and like they have symptoms and they're not going away. Then often I will check and sometimes like treat them, and sometimes doxycycline I find will be helpful for those individuals like the course of it. Um, but really, there's no recommendations to kind of use it like when you're screening for STIs. It's really more like you've excluded sort of the usual culprits, and then you're still symptomatic, and you want to rule out that as a possibility. So that's kind of when I would add on a ureaplasma testing.
Okay, and you're saying it's the same swab that you use for the herpes?
Yeah. So yeah, exactly. Yeah, that's the one that I'm aware of, and
Okay,
that's the one that
and
goes
then
to public health labs.
it does. Okay, and then in terms of treatment, you mentioned you'll treat it in those specific circumstances. Do you know if partners also require treatment if you're treating it?
I can't all remember off the top of my head. I think it'll depend on the situation because again, sometimes it's like it's something that's kind of naturally there. Often people want to have their partner treated. It's one of those things that are a little bit more vague. And I can't remember off the top of my head whether it'd be something that you would treat a partner for. Usually not.
Thanks, that's helpful. One other question, actually, it's not specifically about STIs, but it was actually about bacterial vaginosis. So a comment, can you comment on BV, doing a vaginal culture for postmenopausal women? I get a report back reporting presence or absence of yeast, but it says it's
Yeah.
not testing for BV and why.
Oh, it didn't test for BV.
Yeah.
Oh, then they might not have had BV because usually if you're checking a vaginal CNS, they will comment. Like sometimes there'll be altered flora, but not diagnostic of BV. So those might be your like kind of not technically BV, but they have the BV symptoms. But if it doesn't, it won't. I've never seen it sort of say like I guess it depends on the lab. But usually if there's BV or even like sort of mild potential altered flora, they'll make a comment, but I've never had to specifically ask for BV. I usually just check the vaginal CNS. So it might be a lab thing depending on which lab you're using.
Okay, and actually that's a good question just in terms of that altered vaginal flora. How do you usually manage that? I feel like that comes up quite frequently.
It depends on the person. If they're symptomatic, sometimes, well, to be honest with you, sometimes when I've seen those people and they're symptomatic and it sounds like BV, I've often like just treated them empirically before the swabs have come back anyways. So like someone has symptoms that are very typical for BV, they've had BV before, I'll do the swab at the time of, but I've usually already started them on treatment. And then you get that result back and it was like, well, it could have been BV, not BV, but they've already had the treatment. They feel better by the time they come in. If I haven't treated them and they're still symptomatic, often I'll treat them, but that's just me.
Okay. Thanks very much. And actually just a comment in the chat that they don't, this is from Jordana mentioning that they don't actually test for BV postmenopausal women because I guess it's not validated.
Thanks.
So
Good to
there we
know.
have an answer to that
I
one.
see younger people, I guess, and I'm like,
No worries.
You're on mute, Eleanor.
Whoops, sorry, didn't realize I was on mute there. Apologies for that. Just in terms of, again, I guess a couple of questions people are thinking about BV now. How to treat for recurrent BV? Have you had experience with dealing with that?
no, I'm not the best person because I'm usually reaching out for help for those people as well, to be honest with you.
Excellent. Okay, I'm just noticing the time, so we're going to stop here and just finish off our slides, and then we'll maybe come back for a couple of more questions.
Thanks so much. So just really quick points on some of the communities of practice that we have currently coming up. I'll talk about June 19th in a second. I just wanted to point out the practicing well, as well as the navigating complexity of opioid prescribing and best practice for nicotine cessation, as well as our Pure Connect mentorship. As we go to the next slide, I just wanted to point out our inaugural health equity community of practice that will be starting on June 19th. And we do welcome people that are interested in this. You would have seen some of our speakers from there and our previous session, and we hope to have this be useful. So we want to hear from you and learn from it. And with that, I'll turn back to Eleanor.
Great, thanks very much, Jobin. Next slide. This is just to remind you about the sessions that we've had recently, all available online. So certainly feel free to check them out and watch them over the spring and summer months. And with that, we'll turn back for a couple of questions just to finish off, but I think we've covered most of the content. And our next community practice will be June 27th. So look forward to seeing you, those of you there that can join us. And for now, we'll just turn back to do a few questions with Dan and Rachita. Great. So I think I just wanted to address a couple of questions for you, Dan, that had come up in the chat, because I think you had written the answer to, like, for example, when you're trying to remove a tick, if you could just review with us how you do that for Lyme disease.
Yeah, sure. It certainly takes some practice. But yeah, you want to clean the area first off as best you can. If the tick is there, you want to get some fine point tweezers, forceps, whatever you have available, and grabbing it by the head as close to the skin as possible and pull straight out. So don't twist, don't try to like jimmy it out of there. It's just a straight back one. If it is really, really not coming out, don't try to force it out. Don't like try to dig it out, nothing like that. It's likely to cause more irritation or damage to the skin. You can leave it. It will get popped out by itself over time, regardless. Just make sure that depending on how long it's been there, you just are treating appropriately. For ones that you know are less than 24 hours, like someone who just got the tick on there, it's pretty uncommon that you can't get it out. So just pull it back and it should be fine. If it's an unknown length of time, if the tick looks engorged, it's been sitting there, or often the body falls off, it's just the head. Again, like you don't have to dig at it. Just try to pull it out, and otherwise just prophylax appropriately.
Okay, that's helpful. And actually somebody had mentioned in terms of treatment, so prophylaxis, can you just review with us what you would do in terms of prophylactic treatment?
I would go to the OH guidance document and read it from the list. Like there's a couple of varieties, like there's doxycycline, which is still preferred. Depending, you can use amoxicillin based on age. You can use cefuroxime. The dosing is all in the nice, lovely chart that they have there based on weight for kids, all that sort of stuff. So I would just go there, and that's the best way to do it.
Great. And actually, Harry was just mentioning that pharmacists are now able to prescribe a prophylactic dose of doxycycline. So that's good to know as well, that they might be able to obtain it there as well.
Yep. Yeah, that's in the new expanded scope for minor ailments in pharmacists. So yeah, it's a great point. I totally forgot about that.
Another question I just wanted to clarify, because we had briefly asked about HPV. Can you just review, it is still 2 doses for everybody currently?
So
correct?
the current schedule in Ontario has not been changed to follow the most recent NACI guidance. So the NACI guidance came out last year. Ontario hasn't yet modified the schedule. So right now, for those individuals like children, adolescents getting in the school age program, age 9 to 15, they would be getting this 2-dose schedule as we have right now in the current program. Anyone over 15 or anyone immunocompromised and younger would get the 3-dose schedule following the current Ontario eligibility. If it's going to change, we will certainly let everybody know, but right now you can keep following the current practice based on the Ontario schedule right now.
Great. And just in terms of the time between those doses when you're giving the 2 doses?
So the 2-dose schedule is a 6-month time. The 3-dose schedule is a 0 to 6 schedule.
Thanks very much, Dan. I'm going to ask you a couple of questions just about measles. So how early can I give a second dose of MMR after a first dose was given at age 12 months if the child had been exposed to measles?
So the earliest you can give a second dose would be a 4-week interval of using MMR and MMR. If you want to use MMRV, we wait 6 weeks for the window in the Ontario schedule. So I mean, if they've been exposed and had 1 dose, it's worth a discussion with local public health. But if they were exposed sooner than 1 month after, we wouldn't really be giving another dose that quickly. They've had the exposure if they're going to get it, and that would do the same thing. But 4 weeks is really the minimum interval we can follow to still see a good immune response.
Great, thanks very much. I'm going to turn things over to you, Rachita. Just a couple of questions around TRIC. So for trick testing, does the sample have to reach the lab within a certain time period? Example, within 4 hours for improved detection of infection?
Not for the gnat, as far as I'm aware. I'd have to double check, to be honest with you, on the laboratory websites. Usually the gnats can sit around a little bit longer than like cultures. But I'd have to double check in terms of turnaround time, but that's a great question. You can, depending on which lab you're using, usually if you just go on the website and check as well, they usually have like good information in terms about like storage, like do I put this in the fridge or not, and the turnaround pieces.
Great, thanks very much, Rachita. And just a question regarding suppressive treatment. You had mentioned that, that you might be continuing it for a very long time. Is there any downside regarding long-term use?
Not that I'm aware of. Off the top of my head, I mean, obviously all medications have sort of like contraindications or like interactions. So I mean, if someone developed other health conditions or was on medications that may interact, and I don't know off the top of my head, that might be something that might be worth looking into.
Great, thanks, Rachita. And in terms of pregnant patients who have genital HSV1, do they still require suppression or only for HSV2?
So these are guidelines, and I probably would be suppressing them, but I would imagine they've had some outbreaks in the last year. Personally, yes, I would regardless, just because when it comes to babies, I just don't like taking risks. But the guidelines specifically said HSV2 or anyone who's had an outbreak, I would just suppress them all.
Great, thanks very much. And then just a question in terms of patients, male partner of a female patient with BV. Would you treat the male partner? And if so, what types of treatment?
So technically men don't get BV. However, there was this study or an article that came out like last month or something about treating patients, like the male partners. I haven't looked at the details yet, but there was some, I mean, based on that study, there was some treatment guidelines that they had recommended. Now, this was like based on one study. It's not something that's like out anywhere else. I can't remember the details, but if I remember off the top of my head, it was a very specific group of like a monogamous relationship, like they're like only together. So I don't know how that translates into the real world. So for the moment, I would say no. We usually don't treat the partners. We're just treating the person who's symptomatic. But yeah, the treatment that they looked in the study was really more about like people who are suffering from like recurrent BV with the same partner, like they're always getting it after sex. So it was a very specific scenario that they were talking about.
Right. Okay. So it sounds like it's really going to be quite individualized depending on the actual scenario. Okay, Dan, I'm going to give you the last couple of questions here. I'm hoping by September maybe there'll be less about measles with any luck. But just to clarify, if a child has had their second measles dose early, so they had it before the 4-year mark, will they require then another vaccine? Will they end up getting 3?
No, so only if the first dose was before age 1, then they'll require 2 more doses to ensure we have a good immune response. As long as the first dose was after age 1 and you're following at least the minimum interval between doses, then they wouldn't need an additional dose after that. So like the example you mentioned before, if they got one at 12 months and a day after age 1, and then they got one 4 weeks later, they'd still be considered up to date.
Great, thanks very much. I really want to thank you both for answering so many questions this morning and for your talks that brought us up to speed on a lot of different infectious disease areas. And I wish everybody a wonderful weekend and see you guys all in a couple of weeks. Thanks very much. Take care.
Take care, everyone.